Greg Nigh, Dr. Dan Chong. And we've got a timely discussion. I really want to appreciate and thank you guys for coming on, really spur of the moment. But I felt it was necessary to get some information, get this dialogue. I have so appreciated what both of you guys are putting out around COVID and the pandemic and general health and well-being for people in the country and around the globe. I do want to give an ample and proper introduction. I'm going to start with Dr. Nigh. He's a ND specializing naturopathic oncology, now in his 19th year of clinical practice. He's written and spoken a wide range of topics, including the risk of glyphosate exposure, the role of sulfur in health. He's got a great book out on that. And now COVID-19. I've put his contact information in the show notes, and he is one of the best commentaries on COVID that I've been reading. Plus, I love the man and his sense of humor. We got Dr. Dan Chong, ND, has been licensed naturopathic physician practicing in Portland, Oregon since 2000. We all went to school together. These days, he works with people via telemedicine, specializing in risk assessment, prevention, drug-free treatment strategies for cardiovascular disease and diabetes, as well as general healthy aging, including dementia prevention. Very appropriate for our discussion today. And I've got his contact information on the show notes as well. Welcome aboard.
Thank you.
And so we are going to...
good to be here.
Yeah, thank you. And we'll see how it goes with the dialogue and the discussion. You know, one of the components and why I wanted to do this, though, last week, election week, I did a Dr. Greg diatribe on medical freedom and censorship along those lines. I know you guys have been putting a lot of information out, getting a lot of blowback as well. And so I'm curious on multiple fronts. We're talking COVID. I'm going to say it out loud, right? We're not supposed to be saying COVID on a radio station, but I'm saying it. I'm going to say it a bunch of times. I hope you guys do as well. But we see here in Oregon, all three of us we are all in the Portland metro area. We see this casedemic, and we see our governor and our mayor talking about the cases going through the roof, and boy, we're a bad population and we've got to put things on pause. So I want to talk numbers. What actually do they mean? What don't they mean? Reporting debacle. You know, we've covered PCR testing. I think it's worthy to do it again. Let's start there, and I'm going to lob some of this out. I do want to hear Dr. Chong's approach here too, with the diabetes and cardiovascular disease being like two of the lead risk factors for folks with COVID, and what maybe you're seeing in your practice, or what you've been writing about there too. So I'm going to open it up with that. Let's talk casedemic in numbers. Like, is it useful? I'm going to just lob some of these things at you guys. The numbers, like why are we focused on one number, and is it valuable in any sense of the word?
I'll just say thank you. And Greg Nigh, who's with us here, has been an inspiration to me, and his level of detail of looking at everything in terms of the numbers you're talking about, testing, what's the appropriate things we should be doing, et cetera, I think is as good as anything I've seen out there. So I'm taking the liberty of starting first by saying, go ahead, Greg.
Nice.
Well, yeah, thank you, Dr. Chong.
I try to fill out any spaces that you might need.
So, all right, if I launch into it right quick, I mean, we can spend another whole podcast on the problems with PCR. Dr. Echo, you and I think we reviewed that a lot in the past. And so, I encourage people to go back to that because it is the crux of everything. Everything hinges on PCR and what it's telling us. So there are two concurrent realities that are happening. One is that there is certainly a dramatic increase in the prevalence of positive tests according to PCR. More tests are being done. We're finding more people positive. So, and by definition, that means we're finding more cases. That's one reality. And then a concurrent reality is that there are now in some specific areas around the country, an increase in hospitalizations that are associated with COVID and intensive care. But we have a problem. And this is a problem that I've tried to tease it out in other states, and I have a really hard time finding the data. But in Oregon, by definition, if you've had a positive PCR test within 60 days of your admittance to the hospital, you are a COVID hospitalization. And so we're testing more and more people in Oregon. And every day I check the dashboard. And so more and more people are testing positive, and people are going into the hospital. And so we have this rise of COVID hospitalizations for sure. What we don't have a way of teasing out at least in Oregon, is which percent of the people hospitalized with that COVID positive test are in the hospital because they have the disease of COVID. We don't have a way of sussing that out. Another point that I would make here, and this is something like in the medical research world, there are these two values that we confront a lot, and one is called relative risk and one is called absolute risk. And I'm going to get to my point, but let me just talk this through right quick. So on a relative risk, if you have a treatment that if you give the treatment to 100 people and only, let's say 4 of them die, and then you have these people and you don't do any treatment and 2 of them die. So let's turn that away. 2 die if you give the treatment and 4 die if you don't. Let's say that. So the headline can rightly say that the treatment, it reduced death by 50%, right? And that sounds very impressive. Only half the people died when they got the treatment. That sounds great. That's a relative risk. The absolute risk is that it reduced death by 2%. 4 out of 100 down to 2 out of 100. It's a 2% drop. So I want to use that as a way of talking about what I'm seeing hospitalizations in Oregon. And so I looked at these numbers, and at the lowest point of hospitalizations in Oregon after that initial peak in April, the lowest point that it ever got down to on June 6th, I believe the number was 38 or 39. That was the lowest. And now we are at, the last I looked was 217. Now, we can call that a 420% rise in hospitalizations in Oregon. And it is, if you compare those, just go by those 2 numbers. If we look at and this is what we used to look at the burden on hospital beds and how much it is, because we're trying to not overburden the system. It's actually a 3.8% rise relative to the number of beds that we have available. It's a very, very small rise in terms of the burden on the system, but it's not very convincing to talk about a 3.8% rise, but it is to talk about a 420% rise. So it's not to say that there are not more people in the hospital. There are, but there's a story behind that fact. So
how does that compare to the peak in April with hospitalizations? Did you say that one too, or just from the low point in June to now?
Well, when I was looking at it, I was only looking at the low point in June. The peak in April was certainly higher than it is now. And I'm not sure the exact number. I don't recall the number.
Sure.
It was higher than now, but it's I forget.
Okay. And you could also say that 3.8% rise that you said, that's including the people that may not necessarily be hospitalized because they have COVID-19.
Absolutely, yeah.
And then the only other thing I would add to that, and correct me if I'm wrong, I also understand that it's important it would be great if we could also see a daily number of discharges, hospital discharges. So people that are leaving the hospital as other people are being hospitalized, or people, so we don't see any, so in other words, if you get 10 new people in a day into a hospital diagnosed with COVID, but 4 left that same day, that's 6 new people, technically, right? So, or 6 people burdening the hospital system. And again, this all used to go back to keeping the curve flat and not overwhelming hospitals. This is never supposed to have been about eliminating COVID from the atmosphere or whatever, you know. So I just find when we're talking about what we're supposed to be talking about, which is hospital burden, and we don't ever talk about how many people are leaving the hospital or how many people are in beds actually being treated for COVID-19 versus in beds with something else and testing positive with a PCR test for SARS-CoV-2, those are very different things. And we don't get any of that nuanced information from the media, and it's certainly not what decisions are being made based on, you know, by the governor. So
it is. So on that, I'm wondering, have you looked because we do not have a national standardization as far as testing goes, right? So it basically got fractionated. States are up to their own, you know, demise or success. It's on the states. So what I haven't been able to find any consistency of what a positive PCR test is. Like, you know, I am definitely going to put in the show notes our separate podcast of things that make Dr. Nigh go, where we really discuss the PCR testing. But, you know, what we've seen in the New York Times finally came out with an article saying it's on revolutions, on magnifying. And, you know, once you go above 40 revolutions, we're not sure if that means infection or not. And
I would say 35.
35. Yeah, perfect. I was just trying to be conservative, right?
Yeah.
On that, you know, so I'm wondering, like, when we have the mainstream media talking about this ad nauseum as if we're going to like stop a virus from spreading, we're not even talking about that. We're just talking about positive tests. We have questions on what a positive test is. We have questions on whether those people are actually symptomatic and spreading a virus. We have questions on, you know, how many revolutions, like it's not even apples to apples at this point. Am I gathering this properly?
Yeah, you're spot on. I mean, there is no, we have conflated the idea of PCR positivity with being infected. And those two are, you know, they can overlap, but they're certainly not synonymous. Fauci recently said, and Dr. Chong, you might have been the one to send me this, 2 important things that he acknowledged. One was that asymptomatic infection is never the driver of an epidemic. People that are not symptomatic, infected or not, they are not the main vectors in an epidemic. Now, I wish he would say that on national TV, because that is not the impression that most people have. And the other important thing, which this I know that Dr. Chong sent me, was an interview he gave. And I think, am I right that it was with a news organization overseas? I don't remember.
I don't remember who it was with. It was like Virology Today or something like that.
Yeah,
Not something that the average person wakes up and flips to on their,
right.
on their cell phone.
But they asked him directly about the issue of cycle threshold and how, you know, it's that correspondence between when PCR becomes positive, which cycle does it become positive, and how does that correspond to infection? And he stated very, very explicitly that he feels, I think he said, did he say 30 or 34
35.
cycles?
35. Well, essentially, he started out saying beyond 35, and then he said, you know, 36, 37, 38, 39. These are all possible levels of cycle threshold that some of the tests in the United States are running at. And essentially, he said beyond 35 is dead nucleotide, period, is what he said.
And so again, that needs to be Like, why would he have that knowledge but not have that worked into our system of PCR testing? And in fact, I did a little looking around, and there is a really good summary article that looked at the correspondence between cycle threshold and infectivity. And I believe it's like between 13 and 15, when the CT is around 13 to 15, it is a very high correspondence, like 80%. I'm making a number up, but it's high to infectivity. By the time you get to 30 cycles, or 30 to 35, forget 30 or 35, you're really, actually, you've lost quite a bit of infectious activity at that point. For some reason I want to say 15%. And then once you get above 35, it drops down to like 1 or 2%. So, I mean, the fact is that if we really wanted PCR to be telling us about the high probability of infection, we would use a much lower number. Now, the rationale is that, well, we can't risk letting somebody sneak through. And so we have to use these higher cycle thresholds so that we never let anybody think that they're not infected when they really are. That's understandable, right. But it also paints a very unfortunate picture of what's happening.
And especially when you have the primary virologist on the task force saying beyond 35 is essentially dead, like not infectious anymore. Yeah. And to go with what you were saying, I've seen 2 studies, one of which showed 0 infectivity beyond 35. And the other one was around where you said around, it started just dropping like exponentially after 30.
Yeah.
And the other point, just to drive home that maybe some people aren't aware of who hadn't listened to your last discussion, when doctors get test results back, having run a PCR on a patient, they get a positive or a negative. They don't get told what the cycle threshold is. Apparently you can contact the lab and ask and might be able to get that information, but I don't know very many busy doctors that aren't thinking from this perspective that would do that. And that's everything to what we're trying to figure out. If we want to know who's infectious, we want to know how many cycle thresholds it took to verify that they had any of this genetic material in their nasal passages or whatever. And none of that's being clarified. So all the cases, it's not to say that all the cases, I want to be clear about this because I'm very sensitive to anybody taking beyond what I'm saying. I'm not saying that all these cases are fake or anything like that. It's just that we have 0 idea how many of the cases we hear about on the news are truly infectious or not. And so transparency is like so necessary in the situation, and we get 0 of that.
And the false positivity rate of the testing as well, which I've seen those numbers around 3 to 5%. I don't know if you guys have any clarity on that, or I haven't got
3. I've seen about 3%.
3%. So, when you start then ramping up the testing, we've got all kinds of confusion. Okay, so that's one aspect that I really wanted to drive home for folks, because there are major decisions being made around the globe on that test, which is right there. We've got rot full of issues, right? I mean, I went on the Johns Hopkins website just before the show, just to kind of see, okay, what's conventional land talking about? I mean, they're saying when they look at the 50 states, and I don't agree with everything that Johns Hopkins is putting out, but they're saying, greater 25 to 39 states aren't collecting data in a usable fashion to make any rhyme or reason of the numbers. And it's like, what in the world is happening out there? In that we're now talking about in Oregon, we have this pause, a 2-week pause. So there are some consequences. This is not just like, oh, just 2 more weeks here, folks. And, we can gonna get stuff going again. There's like some serious, significant health consequences for people that we're talking about, beyond just the COVID crisis, right? So I do want to bring those up. I want to look at first really some nuances on these numbers. So we've got it clear as mud, right? How about changing of definitions? This is something that I know that you both have written about over the last 8 months. Around how they're just kind of changing the playing field. It kind of speaks to this Johns Hopkins data center as far as how they're analyzing the data. As you know, I just recently saw the CDC is not going to report on annual flu cases this year because influenza-like illness mimics coronavirus. That was on one of the threads that you all were writing on, and so I kind of chimed in with some of that data. I'm wondering on either of you any opinions on the testing, basically definition changing on how we define the virus. What's this? What is the positive kind of case? Like what actually is a coronavirus person versus a positive test?
Yeah. Well, I'll jump in right quick. Or I don't do anything right quick when I talk, but
that's what we love about
you. So, in saying, the definition of the virus, it actually is quite shocking how we came to have this new virus identified. And just to briefly describe it, right? Once upon a time, when you wanted to identify a virus, you had to isolate the virus. And there's a very clear procedure for how that happened. So that ultimately you end up, after centrifuge and yada, yada, you end up with you can take an electron microscope and see nothing but viral particles in the field. There's no cellular debris, nothing else, just viral particles. That was viral isolation. So then if you were to sample nucleic acid out of that, you're only going to get viral nucleic acids. So they don't do that anymore. Since PCR came about and the way that this particular virus was identified as a novel virus was shocking to me, because they had basically a soup of lots of different viruses from people that were sick. And they ran PCR and they subtracted out all the nucleic acid sequences that they could match up to something else. And then they were consistently having this 30,000 sequence strand showing up over and over. And it didn't match other stuff that they had. So they said, this is the new viral sequence. They did not isolate that virus. It was never isolated. And in fact, when you read the initial publication on how they produced PCR as a test, as a diagnostic test, when they first developed it, they say very explicitly in their write-up that they developed that test without any access to the actual virus or viral isolate. They did not have a virus. They developed a test purely based on PCR sequences derived from non-isolated anything. Mm-hmm. So when we're saying that people are PCR positive, there's a little bit of an inferential ladder that you got to climb in order to get from PCR positive to a particular coronavirus, because that coronavirus was never isolated, and to my knowledge has never been isolated. I've never seen an electron micrograph of only viral particles. Every one that I've looked at has cellular debris in it. So if you extract nucleic acids from that, you cannot know where those nucleic acids came from.
And I would add to that, to me, there are two primary problems with that. Number one, you can have somebody with a different coronavirus in their respiratory passages, and what most people don't realize is that coronaviruses are the second most common cause of the common cold in the human species these days, as far as I understand it. And so if you have enough overlap there with genetic material, there's a theoretical possibility that a PCR test could pick up on a person with a different type of coronavirus and diagnose them with this coronavirus. And then secondly, again, the last I've read, people can have these enough viral fragments left over after a true SARS-CoV-2 infection to test positive on a PCR for 90 days after being infective. So, to me, the false positive question is a totally separate and very important issue. But even when you have somebody that legitimately tests, like the test is accurate, so to speak, and it picks up on SARS-CoV-2 viral particles and amplifies them enough, my biggest problem is that many people can be properly diagnosed as having SARS-CoV-2 genetic material in their body, but improperly called a case or an infectious person. And I'm sure you guys have seen the data on these college outbreaks, which that drives me crazy that they use the term outbreak, which makes it sound like there's all these, I picture a movie in my mind of all these people sick all over the street. And these are not outbreaks. These are clusters of cases, partially derived from literal pop-up testing of healthy people who, could have any mix of the two things I just said. So, another type of virus or fragments of an old virus that they were infected with before that are no longer infectious, or a false positive. Any of those people get added to that case number that we see coming out of these colleges where people are being tested all over the place. So
was that Brown University did that, 26,000 positive PCR tests, no hospitalizations?
I saw the data I saw that somebody compiled of all the college cases that we've heard about was over 69,000 cases. There was 3 hospitalizations from that and no deaths.
Yeah. Wow.
So
yeah, I just today was looking at a graph where it was showing, the percent within each age group, the percent of positive cases, hospitalizations, and deaths. And there was one other thing there, I forget. But basically, almost all the new cases, or the large majority of new cases, are in young, which is, of course, is a headline. But the percent of deaths in fact, the median age of death continues to be, what did I see? It was 82 years old, I think. That's the median age, meaning there are as many people under 82 as there are above 82 who have died, which is just a shocking number. And so the number of, it's like this complete, we were just saying, there's like this, use of the idea of a case to just give us all the impression that this is something very different than it actually is. It really is.
Yeah, and it's important to always make note that none of us are saying this is a hoax or anything close to that. Right. We just want clarity on what we're actually dealing with, and then we want a clarification that the response that we're having is appropriate to what we're dealing with. And I struggle to find any evidence of that, at least at this point in the whole process. Maybe early on when things were more severe. But
unknown. It was unknown at the beginning, but there's a load of data coming in. It's what drives me nuts is okay, now in science, somehow science, if you're pro-science, you're now unquestioning. And it's I know you guys are reading these studies, you're going into the data sets, into how they formulated it. It's not just headline reading, it's mind numbing or boggling of how is this information not getting out, not getting to the decision makers? So, which gives me a good reminder to put a plug in for you all watching this. What the health? This is why I do this show. I get to talk to these brilliant guys here that are actually really being very responsible with reporting what they're seeing and reading. And it looks like we just lost our main guy. So my producer is gone. So yeah, we were just actually talking about censorship before this show. So perhaps the censors got on it. So there you go, Cameron. So on this, it really does make me think okay, what do we do with this information? There was a bit at the beginning of the whole thing was okay, we kind of got censored as a community. And I know Dr. Nigh, you've moved on to new platforms. I've been encouraging folks to do the same thing. It is a real issue that is happening right now around censorship, which is very dangerous. So here it is. We've got two experts reading the data, sharing what they're finding, and we're not really finding the evidence for the draconian lockdowns, shutdowns, masks, social distancing, which I didn't even cover those two. They're such hot button topics. And we're going to talk, I'd love in the kind of the last second half of our show, talk about, okay, so there is so much fear out there. What can we do about it? Like, we're calling into question the numbers. Like, yes, it's a real thing. It's a real virus. We all agree on that. But these numbers of, the median age of death, like to lock down preschoolers and high schoolers and college kids, like, and even the elderly for that matter, of, really getting segmented and isolated. They're dying of loneliness at this point. Like, we're seeing an acceleration of dementia states, and I would say the death rate for all cause mortality. Now, I don't have that study. I was hoping that maybe you guys have come across some of those data points to suggest, like, hey, just by doing this shutdown, lockdown, like divide, I've got patients coming in there like in tears. Their Thanksgivings have been canceled because the whole family is afraid, like they don't want to kill grandma type of thing. And so there's like, they're not able to, be in contact with their grandkids. They're not, the whole social fabric of the nation is really so fragmented. So I'm wondering, like, what other numbers should we be looking at? Number one, like, how are you all framing this? Like, Dr. Nigh, you've shared a couple of them, and Dr. Chong as well, around there's hospitalization rate. There's, I guess, the death rate. Now, this is with a big asterisk around, like, we just called in to question all of the numbers. But if we're just going to look at other numbers as well to show, like, hey, this is a casedemic, the case numbers are going up. This is not the pandemic that we did experience back in April.
I'll say two things and then let Greg say all the smart things. There's two things that I find really fascinating. One is, what I do a lot is I do a lot of comparison of cases, daily cases versus daily deaths in different locations around the world, different geographical areas and places that have been hit hard versus not so hard, places that locked down hard, places that didn't, et cetera. And one thing I see zero discussion with out there is the ones I looked at today specifically were Sweden, New York, New Jersey, maybe one other place, I can't remember, but those we know are three places that got hammered at the beginning and had incredibly high rates of like deaths per million of the population. And when you compare the graphs of their cases and their deaths per day at the beginning, back in April versus now, we see for cases, you see two humps, like the big hump and then this new big growth of cases. And then when you look at deaths, we see a big, like literally parallel hump of deaths per day that parallels the cases per day in April. And then now nothing, like crickets. And early on people were saying, oh, just wait for 2 more weeks when we were talking about Europe was exploding with cases, et cetera. And you're seeing cases go up in Spain, you're seeing cases go up in France, as well as deaths. And yet in Sweden, still nothing is happening in the realm of deaths per day that's beyond anything out of the ordinary. And so it's beyond the amount of time that you could use like a lag in reporting of deaths to explain that. It's just there's no increase in excess deaths happening there. And yet Spain, France locked down super hard. And there's this big difference that nobody's talking about. And how can you explain that and what's going on? So I think that that's a huge part of all of this as we're trying to explain things that we need to be looking at what's happening that's different in those places. I think there was a second thing, but I don't remember now. So go ahead, Greg.
It'll come to you.
Let's see. Well, No, the point that you're making is one that I've noted as well. I mean, I've been watching this increasing disconnect between cases and deaths, and the graphs make it really evident. Another interesting point, I think, is that is the sort of when you juxtapose initial hotspots back in April with what are now hotspots, it's quite telling. The places that had hotspots in April are not hotspotting now. If you talk about it by country, well, Italy, well, they were hotspot then and now they are. But if you look at Italy, back then it was northern Italy and now it's southern Italy. So it kind of speaks to that idea that once you get it disseminated into a population, they have enhanced immunity. They're not getting double hotspotted. Now, I'm not saying that there are no repeat hotspots, but it is a pretty uncanny when you look at what was hot then and what's hot now. They don't overlap very well. In fact, they're kind of mirror images in a lot of ways. So that's one thing that I would say. Dr. Acker, you brought up a couple of questions, just things like masking and distancing and whatever. And two brief things that I would say about that. A very important study that just came out in Nature, which found that people who wear cloth masks, meaning cotton, whether single or double layer, are producing more aerosolized particles than wearing no mask at all, which is, that's kind of a big deal because pretty much everybody on the street, or 80% of people are wearing cloth masks. So that was an important finding in that study. And the second important finding, I thought, was that if you just breathe through your nose, you emit the same amount of particles as if you're wearing an N95 mask. So just now,
say that again. Say that again.
Yeah. So just breathing through your nose, no mask, just nose breathing, has the same amount of particles coming out of you as if you're wearing an N95 mask and talking or something, and to
add to that real quick, the ones with the cloth masks have more coming out of them than if you don't have a mask on at all.
Than no mask at all. Yeah. So anyway, those are kind of interesting things to know. Like if I'm standing in an elevator, just with my mouth closed, because that's how I do things.
You don't just walk around with your mouth open?
I mean, the thing, it's actually, it occurred to me that actually there are lots of people now, because of obesity and just congestion and all that, who don't nose breathe anymore, who actually people have become mouth breathers. And so anyway, regarding masks, that seems interesting to me. Regarding social distancing, it was the Center for Evidence-Based Medicine out of Oxford that actually did a review on that, looked at all the evidence they could find about whether or not social distancing reduces spread of epidemics. They couldn't find it. They could not find any scientific justification for social distancing. Essentially, all of the studies that are used to justify that are based on PCR. They're based on particulate in the air, and they can collect particulate and PCR those particulates, and PCR positive and therefore infectious. But the actual studies on it, there are no studies showing that social distancing is an effective way of reducing epidemic spread. Now, that said, it's very well established that being in close contact with a symptomatic person for over 15 minutes is a high-risk event. Stay social distance in that situation. But in terms of just, being out and about, it's not scientific to say that we should all be 6 feet away. It's tragic now walking down the sidewalk and you can't even smile and say good morning to people because everybody's crossing the street and
they're looking away. I mean, it's
they're shielding their kids.
Yes.
Yeah, totally. I mean,
it's really so fascinating and sad, actually, to see that. Like, even out hiking, I'm like, you're not just gonna walk into a plume of virus. Like, it just doesn't work that way. You're saying it's 15 minutes in close contact.
If I see somebody when I'm hiking literally dive into the bushes, they're more likely to get poison oak, I think, than they are to get coronavirus
I would agree with you.
And I have been denied more scratching of dogs' ears walking on the sidewalk than ever in my life. It's tragic. Like, I love to say hi to dogs, and everybody's like yanking their dog out of the way, like I'm going to give it to their dog.
I mean, it could be on your hand, Dr. Chong, and like give it to the dog, and then they lick their dog's ear.
Yeah, and it's not even to make light of it. It's just using common sense it's so concerning to me to see how psychologically damaged we're getting, especially children, because I know you guys know this, below the age of 7, that's locked in their subconscious for life, potentially, so.
Yeah.
Well, so let's talk about that. So on some of the other repercussions of lockdown, what else are we seeing? I mean, there's some like suicide rates are going through the roof, depression, anxiety. I'm seeing acceleration in my elderly population with mild cognitive impairment and dementia. What have you come across?
I'll just go real quick. Most of what I see is more looking at research that other people are doing. And to me, the most concerning things I've seen are suicides, increased rate of death from Alzheimer's and cognitive decline, and then definitely delayed cancer diagnosis and treatment is something that's come up a number of times in different discussions, studies I've seen, et cetera. So I know that cardiovascular disease rates went up temporarily, but they seem to have kind of normalized the last I heard. But the expanding effect, especially of the problem with cancer diagnoses and delayed screenings and things like that, is massive and is predicted to just continue to grow for like a period of time, and it's unstoppable because we've already sort of started this snowball effect. And then aside from all that, the starvation that's going up around the world is unfathomable as a result of countries locking down and changing and shipping food and different things like that, and scarcity that pops up in populations of people that have, they're on the cusp of going hungry already. It's hard to really process.
Yeah. So my comment on this again, and I'm in the same place, that really this is all just reading the various studies and research that I can find on it. At a global level, the most shocking that I read, and I've posted about this a few times for people that have read that stuff. The World Bank, their best estimate is that in 2020 alone, globally, there will be an additional 74 million deaths due to lockdown. Wow. So that's surplus due to lockdown. And their worst case scenario is that there will be an additional 124 million deaths due to lockdown in 2020 alone. That's the World Bank's estimate, which is, we just can't really fathom those numbers and the human misery that is associated with those numbers.
That's the cure is so much worse than the illness.
Yeah, that's exactly right. Then there was another study that said, I'm gonna mess it up, but it was a study about how many people are being shifted into extreme poverty. And it was another shocking number.
It was 8 million people in the last 3 months in the United States.
In the United States. Yeah. And extreme poverty is like the
line of poverty.
It is extreme. It's really shocking. And I was thinking there was one on a global level. It was some 100 million something globally shifted into extreme poverty. And the definition of extreme poverty that was used, this was, I think, a UN study, that is a buying power of less than $1.90 a day, the equivalent of $1.90 per day. And so, I mean, it was I know it was over 100 million people who were being pushed into that level of poverty just by what's happening, by the lockdown, by the response to to COVID. So, I mean, on so many different levels globally, it really is exactly that. The treatment is so much worse than the disease process itself. And to then segue into, well, what are our options for not becoming ill? And that's actually quite well established at this point. I was really psyched to see that in England, they actually made it a national thing, that they're going to supplement the elderly, people in assisted care, and the critically ill with vitamin D, which is brilliant. Of course.
You would think that's sane public policy. I mean, that's kind of what we have been saying from the beginning. Like, this is absurd. Like, you're saying there's nothing to do but wait at home for a vaccine. Like, that is not about public health or safety or saving lives. And this is the part, like, folks out there listening, viewing this is What the Health. Please share this information. Like, this is the game changer. Like, it's time to get the information out to us all. Like, vitamin D. I mean, yeah. So what do you got? Other things, or more on vitamin D? Because there is a lot to say there.
Well, I mean, I'll make a brief comment. Yeah, vitamin D, there have been a handful of intervention studies, and they're all extremely promising. Another intervention study that was shocking to me was, and I'm forgetting the number of people that were involved, 50 something, but basically it was COVID patients. Every one of them, upon entry into the hospital, they gave them a supplement that contained 3 nutrients. It contained vitamin D at, what was it, like 400 IU, very small. It was very small. They gave them a vitamin B12 at 50 micrograms, which is like homeopathic vitamin B12. And they gave them, what was the other one?
Magnesium.
Magnesium, yeah. And magnesium, the dose on that was like 150 milligrams.
Under the RDA.
Yeah, basically trivial amounts of these nutrients. But even those trivial amounts of nutrients dropped the rate of people becoming critically ill and dying by, I wish I remembered the exact number, but it was
92%.
Thank you.
92%.
Yeah. And all they did was a single dose of these 3 nutrients, and that was it. I mean, it's shocking, shocking, shocking stuff.
Not only are they not doing that, people didn't even know. Nobody's ever even heard of that study. That should have been front page news everywhere. You don't have to die of COVID.
Yeah.
Take some nutrient. Yeah. And I'll also add, the thing I keep hearing time and again from true experts discussing this, no offense to you guys, but like the people whose jobs it is,
the decision makers,
high level epidemiologists,
I get it.
et cetera. These people, what is most shocking to people like that is that this is not how public health is done. We never, ever go after an illness in a vacuum without any consideration for any other aspects of public health. It's never been done before. And public health is not designed to work that way. They're not supposed to make any decisions, especially major ones like we're making, without a full assessment and consideration of all of the different ramifications that could possibly come of that. And that's not being done at all. It wasn't done the first time around. We've now had 8 months to look at all of the things, and now we're looking at making similar decisions again, in spite of the growing evidence that we have of all of the ramifications out there. And then the other thing I find fascinating, I'm not sure if I talked to you about this or not, Greg, but I saw a report that was created in like 2015 or so, and it was an pandemic response report, I believe, from the CDC, essentially guidelines, going over different degrees of severity of a pandemic, and then what type of policy responses we would have based on that degree of severity. And it was 5 levels of severity. And the 5th most intense severe level of severity was comparative to the numbers that we saw with the Spanish flu. So people dying at the rates that we saw with the Spanish flu, which is obviously, no one would argue, way higher than we're getting with COVID-19. And the policy responses to that were less stringent than we are doing with COVID-19. And that, it's like they just took that guideline and just tossed it out the window and went, and I don't know how else to explain something like that. Like, what is the reason behind that? That is the thing that's driving me personally crazy each day, is why is this happening? There's enough evidence to show that we are making some apparently insane decisions, and I don't see any explanation as to why we're doing these things. People out there have all of their own conspiratorial things that they might come up with, and I don't like to get into things. Things like that. I like to just clarify things and trust in the goodness of people, and I can't come up with logical reasons for that. So I wanted to get that in because I couldn't believe it when I was reading that type of information. So
yeah, I think I think it seems to me, and I haven't done any kind of historical look at this, but so much is being driven by projections in this versus what I recall in the past. And what the example that is most prominent for me, which I had just been reading about, I made a mental note, actually a physical note, back on September 23rd, because that's when it was announced that we crossed that grim mile mark of 200,000 cases. And at that time, there were multiple news sources saying that experts predict that we will have an additional 150,000 cases in 3 months. So we had just crossed 200,000. So we were going to be at 350,000 in 3 months. That was the projection. And in fact, Biden at the first debate, or maybe the second one. Yeah, it must have been the second one. He said there would be an additional 200,000 cases by the end of the year. I think he kind of made that number up, but anyway. So so we're now more than halfway to the 3-month mark from when we had 200,000 cases, and which means that we should be somewhere around 75,000 cases because we're halfway there. Actually, we have 40,000 cases, which is tragic, but it's 35,000 cases less than were predicted by this point, which is—
just to clarify, you're talking deaths.
I'm talking about, deaths. Yeah. Have I been saying cases? Crap. Yeah, I meant to be saying deaths.
Right.
And so once again, like there was all this remorse about, the projections were so wrong at the beginning, and we're still doing it. Just like you were just saying, like we're doing the same thing. We're making the same mistakes again. Why are we doing that? Like there's something ain't right about it all.
I would agree. I mean, it sounds very naturopathic of actually asking the question why. Unfortunately, as we know in medicine, sometimes we never get that answer, but it is very valid to ask it, right? So we've got to be asking why. And none of the regulations make any rational sense. I know there's the choir that is bought on to the mandates and like self-policing and like you walk in line here, and it just goes to show what propaganda machine will do, as far as you utter the same words over and over again, and then you start to believe it as truth. And we're saying we're reading the research and the data isn't supporting what reality is showing us, right? I mean, I think we can all agree on that. Yeah. And so, I remember on our first podcast, Dr. Nigh, we talked about hydrochloroquinolone as a treatment.
Yeah.
And I got a lot of blowback from my listeners and folks on my email list of saying, when did you become a Trump supporter? And it was the first time that it really dawned on me, like, this thing has become so politicized, in that I said, I don't know what you're talking about. We're reading the research. We're looking in a pandemic of helping people now. And I've seen you have recently posted, there's more and more evidence to support it as a treatment. Even to this day, you bring it up and people say, that's been disproven, you're a Trumper. And it's like, you know, what happened to critical thinking here in this country and this nation?
Yeah.
And, you know, I think a component is the algorithms and censorship. And, you know, we kind of get put into these echo chambers and manipulated. Now, I'm not saying everybody is in that case, but what I'm looking for is an actual discussion on helping people. I mean, that's why the three of us got into medicine. That's why I called you guys in on talking about this, because you have been putting out some of the most educated discussions around the topic. One, I'm wondering if you all have experienced some blowback on your posting on this topic, because it is so politicized. And then two, I want to end with some hope on there. I mean, you did really drop that big one there on the hospitalization on really micronutrients causing a 92% reduction of the death rate of people with COVID positive symptomatic cases. But so one, curious on what your experiences have been with posting, being very vocal around this information, because it's not, this is not popular belief, but it is the science.
Yeah.
I'll say I've had an interesting combination of two extremes, where I've had a lot of debates, much more than I would prefer to have with, you know, and I will start by just saying, everybody on every angle of this, I know, is a caring person that just wants everybody to be healthy and safe and whatever, but for whatever their own personal reasons, they come at it from different angles. And so I've had some pretty harsh debates, and, you know, I think I might've been asked about being a Trump supporter at least once or twice, just for questioning any of this. As if that's like the worst insult you can have, but whatever. But at the same time, on the other end of the spectrum, I've also had the pleasure of having multiple people reach out to me directly to say how much they appreciate the information that I'm helping provide, as little as I can, you know, and just helping them sort of keep a more logical and broad perspective on things, not go crazy, and be able to feel safe in discussing things and that type of thing. So it's been an interesting experience.
Awesome.
Yeah, well, I mean, when I was over on that other platform, it was, I had a lot of good conversations, but it is much, I mean, Facebook is just dramatically more combative and insulty and all that. And so I'm now, all my social media is on MeWe. And I have found the discussions, even with people that are disagreeing with me, are so much more respectful, and it's just it really, I like it much better. I have had a few people, you know, come at me with, you know, accusing me all kinds of like beliefs that I don't have. So yes, it has, like, the science and the politics have become so intertwined that for many people they can't untangle them. And you know, I don't really care who is endorsing any given scientific opinion. That's not my interest. Like, if Trump happens to be promoting something that is a good idea, then
it's like a coincidence.
So be it. Yeah.
Then I am all behind Trump. I don't give a crap who's endorsing good ideas.
Well, what you are is you're behind the idea, whoever it's coming
right
from.
It's just, yeah, it's just
Pro
the
idea. It's the
And
pro idea platform. There
Yeah,
it is.
Yes.
And I will say the classic thing I've seen as well is people, if I share something, people instantly start to tear down the platform that that it's coming from versus the information that I'm actually sharing. And so apparently, like to this day, I still don't know what QAnon is, but apparently I'm a card carrying member according to some people, or they think I am.
Projections on, right.
Right. So it's, and it's all based, and I made the mistake early on sometimes of sharing something from a website or whatever that I never normally might have looked at ever, and didn't even know it was like a hardcore this or that politicized website. But they for whatever reason, that side of things has had the more willingness to question some of these things. And so now I always do my best to just go to the study that they're talking about or whatever, and just keep that whole issue out of it, because it's not an issue for me, but it is for some people.
You guys, thank you so much for coming on to the show. I really appreciate it. There's so much more to unpack, but we got to go. Everybody out there listening, this is What the Health. We are here Tuesdays from 2 to 3 Pacific Standard Time. Please write us a review. Share this with 2 or 3 people that you know need to get this information, because you're not getting it anywhere else. Thank you all for tuning in. Awesome. Thank you, guys.
Thanks, Michael.
Yeah, man.
Appreciate it.